Hi, everybody. This is Dr. Esquivel again, and I'm joined today by Bethina. Hi, Bethina.
Hi, everybody.
Uh, Bethina, Zach, and Max helped me out in developing this screencast on the third session of our hypothesis-driven history taking. And today we're going to focus on approach to hematuria and acute kidney injury. And let me start off by saying nephrology is always a little complicated. So this is a little bit going to be a little bit more challenging than the previous sessions. So our learning objectives today are first to characterize a patient's complaint of hematuria, describe an anatomic systematic approach to a complaint of hematuria, reproduce a physiologic framework for approaching acute kidney injury, learn how to obtain a detailed family history, and then utilize your knowledge of illness scripts to diagnose the cause of a patient's hematuria and acute kidney injury during your practice sessions. So, when we think about hematuria and acute kidney injury, this is a bit of a more complicated framework. You can see that hematuria can be broken down into whether it's extrarenal or renal, and then acute kidney injury, we typically break it down into pre-renal, intrarenal, and post-renal. So there's a lot of overlap, as you can see in the different subheadings in the causes of hematuria. So what we're going to do is we're going to kind of cover things that overlap together into different systems, and we'll tackle them at the same time, since oftentimes the questions are going to be rather similar. Um, Similarly, the causes of renal glomerular hematuria often overlap with that of acute kidney injury. So those are going to be covered partially also during the acute kidney injury section. So we're going to be kind of toggling back and forth a little bit. As I mentioned, with acute kidney injury, we typically take a pathophysiologic approach of pre-renal, intrarenal, post-renal, and then within intrarenal, we divide it up into glomerular diseases, tubular diseases, interstitial, and vascular causes. So when you're seeing your patient or interviewing your patient in the coming week, what we're going to ask you to do is try to overlap the cognitive frameworks, because some of the causes of hematuria are also causes of acute kidney injury. And what you're going to be doing is finding the diagnoses that overlap, meaning diseases that both cause hematuria as well as acute kidney injury. So, once again, this is a bit more complicated than in previous sections. So, why don't we start off, Bettina? Why don't you help us with characterizing hematuria?
Yeah, so as part of the history gathering process for a patient complaining of hematuria, we would want to ask about the appearance of the urine, such as gross hematuria, as in it's grossly bloody or microscopic, which is a lab finding that some patients may come in with based on a screening at their primary care provider. We would also want to know the onset, pattern, and duration of their symptoms, much like the complaints that we have covered in the past. Was it sudden onset? Is it intermittent? Does it last for a very long time? And if there are precipitating factors for hematuria, such as a recent infection, new medications, a recent history of trauma. We would also want to know whether there is pain associated with the hematuria, as well as any urinary complaints, such as changes in frequency, dysuria, burning on urination, etc. Finally, we would also want to know if the hematuria is associated with any constitutional symptoms, such as fevers and chills. Other components of the history we will want to know, as I mentioned, any history of recent illness and medications, as well as a family history of renal disease and autoimmune diseases. And also the social history of the patient, such as sexual history and toxic habits.
Great. So gathering a family history is something that we do every time we see a new patient. And so I want to make sure that when you're gathering the family history, the one way that you can frame it is by asking, is there anything that runs in the family? This is often something that will elicit a response from the patient. But oftentimes you may need to actually inquire very specifically about their parents. Are their parents still alive or are they deceased? And were there any illnesses that the parents actually had that led up to their death, or was there a chronic illness that they had? You may also need to be very specific about certain illnesses or symptom complexes. So you may need to ask, is there anybody in your family on dialysis, or was there anybody in the family who had a kidney transplant? Make sure to not forget about the siblings as well as the children's health statuses. Um, and remember that when you're gathering the family history and documenting it in the chart, it's never enough to say non-contributory or unremarkable. For the purposes of documentation and billing, this is actually considered to be inadequate. With that, what we're going to do is that we're going to go to the approach to hematuria. And as you can see, when we go down the framework of extrarenal and renal, there are several diseases that are common, or systems are commonly involved. So nephrolithiasis affects both, or causes both extrarenal and renal hematuria, infectious etiologies, neoplastic processes, trauma, uh, genital anorectal issues may be pertinent, and drugs as well. On the other hand, when we think about renal non-glomerular causes versus glomerular causes, one of the things that's common to them is familial history. So this is something we need to actually um, ask about. Drugs are also something to actually ask about for patients with hematuria. So we're going to now cover some of the most important illness scripts in the upcoming slides.
So we'll start off with nephrolithiasis. One of the predominant symptoms with nephrolithiasis is flank pain that may radiate to lower abdomen or the groin. The pain tends to be colicky and intermittent in nature and is often associated with nausea and vomiting. Additional symptoms that you may see in patients with nephrolithiasis include hematuria, as well as symptoms like dysuria, urgency, and frequency. Some risk factors for nephrolithiasis include decreased fluid intake and dehydration, a personal history of stones in the past, or a family history of nephrolithiasis, as well as hypercalciuria and anatomic abnormalities that may predispose patients to this condition. Nephrolithiasis is pretty common, with an estimated prevalence of 1 to 20% during people's lifetimes. Next, we have infectious causes, which include cystitis and pyelonephritis. So cystitis is what we commonly think of as an uncomplicated UTI. So that could present with dysuria, frequency, and urgency. It may be accompanied by gross hematuria, as well as fevers, chills, and suprapubic pain. With pyelonephritis, you would typically expect to see flank pain, more often associated with fevers and chills, as well as nausea, vomiting. So risk factors for cystitis and pyelonephritis include female sex, as well as recent sexual intercourse or new sexual partner. So for prostatitis, which may also present with hematuria, risk factors include urogenital instrumentation, usually in older men. Additional symptoms associated with that include urinary symptoms like straining, hesitancy, a weak stream, and incomplete voiding. Another thing to keep in the back of your mind is schistosomiasis, which is a parasitic infection that often affects the bladder. This is pretty rare, but you may want to ask about patients' travel history to endemic areas, which include Africa and Southeast Asia. Neoplastic processes that may cause hematuria include renal cell carcinoma, bladder and ureteral cancer, as well as prostate adenocarcinoma. So for renal cell carcinoma, oftentimes it is asymptomatic, but may present with a triad of flank pain, hematuria, and abdominal mass. It may also be associated with anemia and cachexia. With bladder cancer, it is also commonly painless in most of the patients, but you may have urinary frequency and urgency. And with prostate cancer, it is also often asymptomatic, but you may have symptoms related to metastatic lesions such as bone pain. Risk factors for these malignancies include a history of tobacco use. Men and older individuals are typically at higher risk, as well as Black ethnicity. People may also have genetic predispositions for some of these cancers, which may include history of cystic disease, which we'll discuss a little bit later, as well as some hereditary cancer syndromes like von Hippel-Lindau for renal cell carcinoma. Prevalence is about 10 to 40% in patients with hematuria were reported to have a urological malignancy, and the lifetime risk of developing prostate cancer is about 15.3% in the US. Next, we have trauma. So a history of blunt or penetrating abdominal injury is important to document. And you may also have hematuria associated with pelvic fracture, as well as penile injury or penile fracture. Gynecologic or urologic surgeries can cause trauma that result in hematuria, as well as a traumatic Foley catheter placement, especially in people with a history of benign prostatic hyperplasia. And the frequencies are listed on the slide. For rhabdomyolysis, you would typically see a classic triad of muscle pain, which may range from mild to severe, as well as weakness and swelling of the injured muscle, and tea-colored urine that could range from pink, reddish brown to black. You may also see associated symptoms like fever, nausea, vomiting, malaise, as well as oliguria or anuria. Risk factors include a history of heavy physical exertion, especially if the individual is not used to heavy exercise. Risk factors also include an elevated BMI or deconditioned state. This could be a sedentary person or someone who's very ill and in the ICU, for example. Another risk factor is dehydration, as well as current infection, statin use, and trauma. The prevalence is not very well documented in the general public, but it's been estimated that patients with traumatic injury has 85% of these individuals have rhabdomyolysis, and about 20% of ICU patients. Some medications that can cause hematuria include anticoagulants, which is very commonly prescribed for conditions like arrhythmias, cardiac conditions, stroke, valvular disease, people with coagulopathy, as well as a history of DVT and PE. So anticoagulants can directly cause gross hematuria, or it can exacerbate an underlying cause of hematuria, such as a bladder cancer. Another drug that can cause hematuria is cyclophosphamide, which is used as chemotherapy for solid tumors and lymphomas. This can cause hemorrhagic cystitis, and the hematuria typically appears within 48 hours of onset of initiation of treatment. Some vascular causes of hematuria include renal infarction, renal vein thrombosis, and malignant hypertension. For renal infarction, you can have the underlying cause may be a thromboembolism, so you can look for a history of AFib or a history of hypercoagulability. It can also result from atheroembolism in a patient, especially in a patient who just had a cardiac cath. You can also have in situ thrombosis. So you look for local vasculopathy. This renal infarction typically presents with flank pain, nausea, vomiting, as well as fever. For renal vein thrombosis, the onset is typically acute with a very much overlapping symptomatology as renal infarction. It can be it can also be chronic and asymptomatic. So you should look for causes of hypercoagulability or a malignancy. Malignant hypertension is when blood pressures are so elevated that it causes end organ damage. So in these patients, we want to find out what the underlying cause of the hypertension might be, which could be due to drug use, medication non-adherence, renal vascular disease, high catecholamine state, or high aldosterone state. The prevalence of renal infarction is reported in 2% incidence among patients with AFib, and renal vein thrombosis is relatively rare. For some of the familial diseases that can cause hematuria, the presentation can be seen in gross hematuria with or without cystitis symptoms. So additional symptoms could include low back pain, abdominal pain, or flank pain, and the pain can be acute or chronic. Associated symptoms include abdominal distension, early satiety, nausea, vomiting, and GERD. All of these are due to sort of the compressive effects resulting from the changes in the kidney. But these patients can also be asymptomatic. Two causes of these cystic diseases include autosomal dominant polycystic kidney disease, which is estimated to affect 12.5 million people worldwide, which is also estimated to be 1 in 1,000 to 2,500. Risk factor to look for would be a family history of similar symptoms or an established diagnosis. Associated conditions with polycystic kidney disease include hepatic cysts and intracranial aneurysms. Medullary sponge kidney is much rarer, affecting about 5 per 10,000 to 100,000 people. Similarly, you should look for a positive family history, and this condition is associated with some other congenital syndromes like Beckwith-Wiedemann syndrome, Wilms tumor, as well as horseshoe kidney.
Yeah, ADPKD is the most common genetic disease probably, and so it's really not that unusual. And it's important to keep that in the back of your mind in patients who present with abnormal creatinines or somebody who comes in with gross hematuria from hemorrhage in the cysts. So think about that in the back of your mind.
So additional familial diseases to keep in mind include Alport syndrome, Neopatella syndrome, and loin pain hematuria. The presentation is characterized by hematuria that can be microscopic or gross, as well as a positive family history. So these are rarer conditions than PKD, with Alport syndrome reported to affect 1 per 5,000 to 10,000 people in the US. It's a rarer cause of ESRD in adults than it is for children. It is an X-linked condition, and it can be associated with sensory neurohearing loss, ocular anomalies, and leiomyomatosis. Neopatella syndrome is estimated to affect 1 per 50,000 people. Similarly, we want to look for family history. Associated features include anatomic abnormalities affecting the nail digits, limb, and pelvic structures, as well as sensory neurohearing loss and glaucoma. Loin pain hematuria has an estimated prevalence of 0.011%. In addition to family history, you may want to look for associated features such as recurrent and persistent flank pain and nephrolithiasis.
Yeah, loin pain hematuria syndrome is often misdiagnosed as either pyelonephritis or nephrolithiasis. So keep that in the back of your mind. It's usually more common in women, and it is associated with autosomal dominant forms of Alport syndrome.
So extrarenal causes of bloody urine also include vulvovaginitis, which can present with any combination of pruritus, irritation, erythema, and discharge. Risk factors include multiple and or new sexual partners, uncontrolled diabetes, which is associated with candidiasis, as well as low estrogen states. So in postmenopausal women, who may have atrophic vaginitis. Anal fissures is another cause that's associated with severe anal pain, which may be described as burning or tearing. It's worse when the patient is having a bowel movement and can last from minutes to hours. This usually presents with bright red rectal bleeding and may be precipitated by constipation or diarrhea. Risk factors include constipation or diarrhea, as well as anal receptive intercourse. The epidemiology for this, it affects all ages and genders, and it's relatively common.
Yeah, the only reason why we included this slide is that it's important to think about whether or not the blood that people identify in their urine is actually coming from the kidneys or the bladder, right? Because sometimes it's actually can be kind of confusing for the patients. So we're going to move on now to the approach to acute kidney injury. As we mentioned, we're going to touch on pre-renal causes, post-renal causes, and intra-renal causes. And some of these things we've already seen in our previous slides and our previous sessions. So hopefully it'll just be a review for you.
So we'll start with pre-renal AKI. One of the common causes of AKI is intravascular volume depletion. The symptoms for this can have different categories of underlying causes. One are symptoms caused by hypovolemia, which include oliguria, anuria, or polyuria. This can present with dizziness. The patient usually has orthostatic hypotension. Patient may have an increased thirst in recent history, as well as lethargy and fatigue. The other category of symptoms are caused by electrolyte imbalances as a result of the volume shifts. That includes muscle weakness, arrhythmias, confusion, and seizures. So the intravascular volume depletion can be caused by volume depletion, which is typically associated with a history of reduced fluid intake, blood loss, or burns. And these can present with nausea. These patients can have a history of nausea, vomiting, and diarrhea, in other words, fluid loss, or the depletion can be secondary to third spacing as a result of sepsis, pancreatitis, intestinal obstruction, or crush injuries. These patients typically present with a history of fever and pain. Moving on to post-renal AKI, this usually results from first an obstructive process. This can be an obstruction of the ureter by stones or strictures, or it can be a bladder obstruction, commonly seen in patients with a history of BPH, prostate cancer, or it can be drug-induced, especially with use of anticholinergics. This leads to a subsequent hydronephrosis, causing pressure backing up into the renal pelvis and leading to pressure backing up into the collecting duct, and this results in the pain that the patient may experience. And finally, this culminates in an impaired renal function as seen by a drop in the GFR, and this can be a sequelae of acute or chronic kidney failure. Risk factors for post-renal AKI include stones or BPH, which is seen in older adults, and people with a family history of the condition, obesity, and diabetes. The prevalence, obstructions are pretty common, but only when you have pretty severe obstruction would you see AKI, and it's more frequent in females from the age of 20 to 60, and more frequent in males after the age of 60 as a result of BPH. So for intrarenal AKI, we'll discuss glomerular causes, which can be categorized into nephritic syndrome and nephrotic syndrome. So for nephritic syndrome, the presenting symptom may be hematuria, and you may see acanthocytes in the urine. These patients may also present with oliguria and hypertension with or without edema. You may also see non-nephrotic range proteinuria, so some protein, but not as much as you would see in nephrotic syndrome. You can also see sterile pyuria as well as azotemia. Nephritic syndrome in adults is most frequently IgA nephropathy. And in children, it is most commonly post-strep glomerulonephritis. It can also be IgA nephropathy as well as lupus. For nephrotic syndrome, the predominant symptom may be edema. In early stages, the edema could be predominantly around the eyelids, so presenting as puffiness upon waking. As it progresses, it may progress to facial and ankle edema, and in late stages, you may see diffuse edema, anasarca, as well as pleural effusion. Complications associated with this include hypovolemia, infection, as well as DVT and PE as a result of the loss of protein CNS, which helps with coagulation. You may see large amounts of protein in the urine, greater than 3 grams of protein a day, as well as microscopic hematuria that happens in 20 to 40% of the cases. For nephrotic syndrome, the most common cause in children is minimal change disease. In white adults, the most common cause is membranous nephropathy, and in African American adults, the most common cause is focal segmental glomerular sclerosis.
Yeah, clearly here the history is going to be just a starting point in you developing a diagnosis of these diseases, because you're going to need to get some additional physical exam findings and laboratory data to actually really confirm this. But it's important to remember how to distinguish nephritic from nephrotic.
For proliferative causes, that can include systemic vasculitis, which presents with constitutional symptoms such as fever, weight loss, fatigue, anorexia. It's also very important to ask about organ-specific symptoms. So taking a very thorough review of systems is really important for this. So you may see associated symptoms like shortness of breath, cough, hemoptysis, or lower extremity edema, joint pain, arthralgias, skin rashes, Raynaud's phenomenon, neurologic complaints, and headaches. The timing is usually subacute to chronic, and it's gradually progressive. The risk factors include older age from 65 to 74, and for small vessel polyarteritis nodosa, it's more common in men versus women. It's relatively uncommon to see this.
Yeah, you have to have a really high level of suspicion in order to actually really think about these things. But I think it's important to really spend some time gathering a good review of systems to really clarify whether the AKI or hematuria actually involves other parts of the body as well.
A cause of intrarenal AKI is acute tubular necrosis. This is typically due to a prolonged period of hypotension, so greater than 30 minutes. It can also be secondary to toxins. This includes myoglobin metabolites and rhabdomyolysis, or drugs that cause death of tubular cells and resulting in renal insufficiency. High-risk medications include aminoglycosides and amphotericin. Associated symptoms are oliguria, anuria, nausea, vomiting, edema, and cognitive impairment. Risk factors include liver disease. The cause for this is multifactorial, including impaired toxin clearance, and another predisposing factor is diabetic nephropathy. The prevalence of ATN was estimated to be the sole cause of 45% of cases of acute renal failure. Interstitial nephritis is also a cause of intrarenal AKI. So this could be acute or chronic. Symptoms can be nonspecific, such as oliguria, malaise, anorexia, nausea, vomiting. There may also be the presence of a triad of hypersensitivity manifestations like low-grade fever, rash, and eosinophilia, which you won't be able to get on history, but we'll be able to see on labs. Associated symptoms may include arthralgias, microscopic or gross hematuria, and flank pain. And the risk factors, one major category would be medications, and these include antibiotics, NSAIDs, diuretics, and PPIs. Systemic conditions can also predispose to interstitial nephritis, including autoimmune causes like lupus, lymphoproliferative causes like multiple myeloma, as well as granulomatous causes like sarcoidosis. And infections can also cause interstitial nephritis. The prevalence is higher among older adults, especially those who are taking the medications that predispose to this condition. One of the vascular causes of intrarenal AKI is hemolytic uremic syndrome. The symptoms typically include a triad of acute renal impairment, thrombocytopenia, and microangiopathic hemolytic anemia, or otherwise known as MAHA. The acute renal impairment may manifest as elevated creatinine, oliguria, hematuria. Thrombocytopenia may manifest as ecchymoses, and the MAHA, usually you would need to rely on labs, but you may notice jaundice in the patients. And so on labs, you would see low hemoglobin, schistocytes on a peripheral blood smear, a negative Coombs test, as well as high LDH and low haptoglobin, indicating hemolysis. Risk factors for this include recent gastroenteritis, especially the E. coli O157H7 strain. So for this, we should do a thorough review of travel and dietary history, look for a history of fever, pain, nausea, vomiting, and bloody diarrhea. And less often, this HUS can result from a respiratory illness, such as strep pneumo, and a family history is also important to keep in mind. The prevalence is highest among children under 10, and it's higher in rural areas in the summer and fall. And it happens in about it happens 3 out of 100,000 cases yearly in the U.S. And finally, we have medications, which can cause pre-renal, renal, or post-renal AKI. So for pre-renal, we should keep in mind patients' history of diuretics use, NSAIDs use, as well as any use of ACE inhibitors and ARBs. For renal, intrarenal causes, like we discussed, includes antibiotics like penicillins and aminoglycosides, chemotherapy agents, NSAIDs, proton pump inhibitors. Should also take a thorough history of patients' supplement and use of herbal medications, as well as contrast agents that patients may have gotten for imaging. Post-renal causes include anticholinergic agents.
So the rest of the slides are going to go through some of the more common glomerular diseases that you may encounter. And so we're going to save this as for you to review on your own. So post-infectious glomerulonephritis, IgA nephropathy, membranoproliferative glomerulonephritis, for which it's important to assess for risk factors like chronic hepatitis C or Hep B, heroin use, and other systemic immune complex diseases. Lupus is a very common disease that will manifest in the kidneys. Henoch-Schönlein purpura is a more unusual small vessel vasculitis. And then anti-GBM is another disease that you may have learned about in your renal module. In addition, there are other diseases that tend to present in a non-proliferative glomerular fashion, which you see here, such as minimal change, membranous nephropathy, and FSGS. So I know that's a lot of information, and so what I want you to do is when you actually talk to your patients, I want you to think about these two frameworks, and I want you to think about diseases that are overlapping between them, and those are the diseases that you really ought to be focusing on when you we're trying to figure out what might be causing the hematuria and acute kidney injury in the patient you will be encountering. So, Bettina, thank you once again for your time and for all the effort in putting together these teaching tools.
Thank you, Dr. Esquivel. Hope everyone finds this useful.